We've talked quite a bit about treatment of metastatic disease now. Obviously, there is heavy investigation of using many of the medications we've discussed today also in the non-metastatic space. Over the last 10 years, many such trials have been conducted, and we've been anxiously awaiting the results. And over the last 2 years, we have now started to see the first efficacy results come back for some of these large phase 3 randomized trials conducted in the adjuvant space. There was surprise after it was seen that on the randomized Hsieh trial, 1 year of TKI therapy post-operatively in patients with non-metastatic disease failed to improve disease-free survival compared to placebo. And shortly thereafter, we saw the results of the STRAC trial, which was an industry-sponsored study of one of these medications, sunitinib, also given post-operatively for 1 year compared to placebo, and here we saw improvement in disease-free survival. This, of course, has spurred many discussions now, and ultimately the impression is that not only the difference in patient characteristics going onto the trial, specifically the degree of high-risk versus low-risk patients, but also clear cell versus non-clear cell variants, and secondly, dose exposure, meaning how hard patients were pushed to stay on full dose during the course of the trial, may have had a major impact that explains the difference in outcomes seen on these two studies. For community oncologists, it's important to bear in mind that sunitinib has no FDA approval as of yet in the treatment of non-metastatic disease. And the standard as of today in the adjuvant space remains active surveillance.
Probably one of the most exciting areas in, besides combination strategies for patients with metastatic disease is trying to actually increase our cure rates for patients with locally advanced disease. As most are aware, there's only been one positive trial in the adjuvant setting. We heard about that this past year, called the STRAC trial with sunitinib. At ASCO 2017, we see the results of a negative phase 3 trial called the PROTECT trial, evaluating pazopanib as a therapy in the adjuvant setting. Although the trial was negative, when one looks at subset analysis, it appears that the full dose 800 milligram cohort seemed to have some degree of benefit, which brings to mind why STRAC may indeed be positive and other trials may not be. In the STRAC trial, patients were started at full dose of sunitinib, 50 milligrams, and the dose intensity reported out in that trial was greater than 40 milligrams. Unlike other trials that may be done where they start at lower, less effective doses because of toxicity concerns. Beyond TKIs in the adjuvant setting, we have great hope that IO therapies may provide great value as adjuvant options. And there are several clinical trials. For instance, I'm aware of a phase 3 trial of Pembro in the adjuvant setting for patients with high-risk renal cell. The advantage of an IO strategy is hopefully less toxicity that allows patients to complete a prescribed length of time of adjuvant therapy. Our goal is not only to improve disease-free survival, but to improve cure rates.
The most important thing at this juncture is when we get into the golden age is really we need to think about whether we can cure patients instead of just kind of put them under control. And then we should actually start to think about that possibility. But we also need to redefine the definition of cure. The unmet need with the golden age arrive, we have 12 drugs FDA approved in the US. We are going to double the survival, but we cannot double the survival just by randomly using the 12 drugs in any sequence. We need to use them in different ways, mainly based on mechanisms. As I said, there are many drugs, but at this moment we can think of VEGF as one arm, mTOR is one arm, VEGF FGF is one arm, VEGF CMET is one arm, and PD-L1 is one arm. It's likely CTLA-4 will be one arm. So there are many, many different options available. The unmet need is we have migrated through an era, I call it dark age. We don't know how to treat. We're going to tell patients that we're going to give 100% toxicity, you can live a few more months. To a modern age that we can double their survival, but most of them still die of their disease. So in the golden age, what we need is to strive for curing some of them. The definition of cure, I think, I really like to talk about this a little bit in terms of the definition of cure. We all have cancer, I think, in human. Okay, think about it. We have each DNA, we have 3 billion base pair of DNA. Each single cell have 2 copies, so we have 6 billion base pair of DNA. We have about 50 trillion cells in our body. And with the turnover is hundreds of billion cells every day. So the transaction of nucleotide, I call it gazillion, is a real 21 zero behind 1. Okay, so how can you have not develop any error? It's impossible. So there's error. So we always encounter facing the error from happening. But the reason we didn't develop tumor every day is because our immune system actually detect when they have early mutation, they get rid of it already. So that's why I think we all come with the mutation. We all come with the cancer, most of the time in our life. But it never manifests as disease because our immune system actually doing a very, very good job. Okay, so in the old targeted therapy era, people need to take medication every day. So actually remind the patient that you have disease every day. So in the era that I call golden era, or even diamond age that I kind of wrote it in my review in 2025. The idea is basically if you put a patient, get them the most effective treatment, and get their disease into maybe invisible or very, very stable, and you can take them off treatment. And they just monitor their disease. If after 2 years their disease doesn't change at all, or there's nothing coming back, they should live their life. So the modern definition of cure shouldn't be, in the past it's like, if you live 5 years or cure. No, it's not. But nowadays, it's how do you define cure? It's almost impossible to, any patient that had cancer encounter in their life, they always think they have cancer their whole life, till the day they die. So I think the definition of cure should be changed, and everybody need to kind of embrace the new definition. Otherwise, we're getting nowhere.